significantly above that. Because there's enough stuff out there that I think somebody could attack you and say why, even though it's not really based in the literature. Does that make sense? So that's just my warning. I mean, it's not really a scientific argument, but be careful because, you know, it's not unheard of to have an issue with this steroid. Okay, I think we just said it. So, caution for laminitis. The typical aftercare is 2 days in a stall and then return to work over the next week. So they get about a week of being off and then light work. The other issue, we touched on this, was joint infection of the liver. So meaning you can either get an actual infection there, or you can get just an inflammatory flare where the horse gets painful, gets swollen, but it's not actually infected, it's just responding in an irritating way to the injection. So all those things to talk to your client about before you do it. Put in your discharge instructions saying look for lameness, look for swelling, look for something unexpected after this discharge. Another thing, we're leaving the steroids now. So IRAP, we have a product here called ProStride, which is very similar. It's kind of that plus a little bit. So IRAP is interleukin-1 receptor antagonist protein. Now what it is, it takes blood from the horse, as you're showing here in the middle. This is one system, this isn't quite the one we have, but I'll just describe this. So you see there's these little beads in the syringe? Take blood from the horse, and then you incubate it with these beads. And beads have a little antibody antigen deal they do, and they basically are eluting the interleukin-1 receptor antagonist protein out of the horse's own blood, and we're concentrating that stuff through a little process, and then we're going to inject that back into the joint. Okay. So interleukin-1 is one of those inflammatory proteins, right? So interleukin-1 receptor antagonist would be like the anti-IL-1. So what we're doing is taking the horse's own anti-inflammatory molecules, concentrating them into a little syringe, and putting that right in the joint that's inflamed. So, you know, it's all autologous, it comes from him, it's natural, blah, blah, blah. A little bit more expensive than steroids, but you don't have that potential steroid degenerative cycle thing that you can start. So I like this a lot for younger horses with less severe arthritis. If I have some synovitis or something that's starting off in a younger horse, but I really want to keep that horse going as long as I can, this is one I like to use. And our product here is called ProStride.
You said you take blood and mix it, so like blood from the goat?
Yep, exactly. Yeah, so this is a needle, this is the horse's neck here. We're just taking the blood through a little butterfly catheter or whatever. This syringe here is this one, see these little gold beady things? And then you, the one I'm showing here has about a 24-hour incubation. It kind of goes in a little warming thing that rocks it back and forth and gets the protein in the blood to bind to the antibody or antigen or whatever on the beads, and then extract that off. The one we have doesn't have the 24-hour thing. You can process it in like 20 minutes. But it's kind of done in a simpler way.
How often would you do it?
What's that?
How often would you?
Oh, how often do you have to treat the horse with this? About the same as steroids,
Okay.
you know, so you're kind of telling them 4 to 6 months or so. We charge $450, I think, for our ProStride joint injections. Probably about half that.
I'm sorry. Can you talk like
Oh, I'm sorry, guys. I'm not yelling. So he was asking like how often do you have to do this? About the same as steroids, about 4 to 6 months is what you hope. I don't. Yeah. You're not really doing it and then curing the horse. You're going to keep maintaining. I don't find as many horses respond to this as do steroids, but the ones that do respond, it's nice because you don't have to feel like you're putting the degenerative stuff in the joints at a young age.
So for that 450, how many joints was it?
Well, so if I had a stifle, theoretically the company tells you really ought to use more than one kit. So I try to stretch it because it's expensive for most people, you know. So like a small joint, one kit, treat them. You know, I can't really split that between 2 joints. But if I have a big joint like a stifle, they're really saying, well, it'd be better if you use 2 kits, which is like 900, right? So I don't often do it for stifles. So then we have a variety variety of polysulfated polysaccharides. The most common one you'll see here is Equine, which I don't want to say horses came before they started using it in dogs. So it's an IM usually, but they have a product you can put right in the joint, so it can be IA. Basically we're not entirely sure how it works, but there's some inhibition of some of the inflammatory cytokines and enzymes, and also just an overall anti-inflammatory effect. Penicillin is one, they say is like a generic Equine. I don't like it very much, but I just listed it on here for you guys. Very importantly, if you're putting it right in the joint, it has been shown to increase your chances of septic arthritis. So make sure if you're doing the IA one, you do add the antibiotic too. Then we have hyaluronic acid itself. I'm not sure why that is coming up like that. So hyaluronic acid itself, Legend is one of the brands here. Can do it IV, can do it right in the joint, intra-articular. We're not entirely sure how it works again, but it's got an overall anti-inflammatory response. It's not as strong as putting the steroid or putting the Equine, those PS gags in there. This is more of like a mild problem, or the horse really isn't having any problems, but we've got like an expensive high-level show horse that we're going to keep going with as much as we can to prevent any problems. So some of those horses will get an injection, every couple weeks or so of that, or so not super strong, but a lot of the show horses will be on it in conjunction with other things. So then there's a variety of oral joint supplements, so many that I cannot possibly name them all. What I will usually do is tell the clients the couple that I use a lot and I trust, or that have some clinical studies behind them. There's a lot of garbage out there. Actually, there have been studies done looking at the 100 or whatever of these joint products you can buy in the random tack stores and catalogs and things like that. Many of them don't even have the active ingredient in there when they tested them, so a lot of garbage out there. Be really careful with stuff that makes a lot of promises, says it treats colic, it makes your horse shiny too. It's colic. So the couple that I like, Equine is probably my favorite, especially the ASU one with the avocado unsaponifiables. This is a company that's actually Nutramax. You guys are probably familiar with like Equine and stuff in dogs. I really like this stuff. They put work behind it. A lot of people use it. A lot of actual evidence that it helps. Is it going to fix the horse that has like a big old osteophyte? No. This is like a minor problem, just to kind of give the horse a little boost, maybe like a 10% improvement sort of thing. Or use this plus do your steroid injections and your Equine and stuff like that. So you can add all these things together. This is like a little help, but it's not going to change the world for a super lame horse. Other stuff you can do, stem cells have mostly been used in tendon and ligament injuries in horses, and we're going to talk about those a lot when I do that lecture, but there have been some studies looking at them in joint disease. I think they're more common in joint disease in small animals than they are in horses, but it's out there a little bit. Extracorporeal shockwave therapy, so shockwave, we'll talk about it as. Have been a few studies looking at hock pain especially, and shockwaving these horses. I don't do, well, not many of us do that a lot. They've actually shown that a lot of the benefit to shockwave is really that it has a desensitization effect. So it's actually illegal, I think it's racehorses in this country or one of the others. It's not legal to shockwave the horse before a race because you're numbing it almost. Diagnostic arthroscopy, and this is an arthroscopic image here. There's your cartilage. Here's some of the synovium. That's more useful as a therapy if you have an acute problem. So, if you have an OCD fragment or the horse has an acute trauma and you think you need to go in there and clean up something that's fibrillated or something, that's more useful than trying to go in and scope a joint in an arthritic horse that's been that way for a couple of years. There's, that's diagnostic, but we don't really often even need to do that rather than therapeutic. So here's our other A word. We were talking about ankylosis before. Okay, so this is arthrodesis. All right, so if your steroid injections aren't working anymore, and your Cosequin isn't doing anything, your IRAP is pointless, and all the other stuff has stopped working, you're beyond any other treatment, you need to do one of these things, or the recommendation would be to do one of these things to make the joint go away and stop moving. So arthrodesis is basically you're going in and you're putting plates and screws to fuse a joint surgically. All right, so when you do an arthrodesis, you take a picture afterwards and there's metal in there, okay? So there's metal in there. You're doing something with an internal fixation. Now, some of these joints can respond really well to this, and you're actually able to go back and use them athletically. The low motion joints, especially the proximal and phalangeal, the pastern joint, one of the carpal joints that's the lowest of motion in the carpus. Same with the distal hock joints, that just are low motion joints. You can expect a reasonable prognosis and actually potentially athletic use out of these horses. Now, high motion joints, like this fetlock, for example, the fetlock's supposed to close, open and close. I'm not going to make a riding horse out of that. The idea with this is that you have, like a fracture or bad arthritis or something like that, but you want to use the horse for broodmare, or you just want it to be pasture sound. So high motion joint, you're not going to do an arthritis and be riding the horse afterwards. You're going to have a horse that's ambling around the field, visibly a little gimpy, but comfortable enough to keep living out there in the field. Right, so that's arthrodesis. So we talked about so we talked about arthrodesis. I mentioned ankylosis before. Now remember, ankylosis, if the body's doing it itself, is just trying to fuse that joint, that's just ankylosis. Ankylosis, if I'm trying to help it, is facilitated ankylosis. Okay, so this is low motion joints. You're not going to do this in a knee, you're not going to do this in a stector. Low motion joints. A couple ways to do it. This image here is showing a drill bit going across the joint and fanning around, basically to tear up the cartilage and try to create weld spots. So if you get rid of most of the cartilage, at least in there, and then stabilize that joint for a while, the bone is going to grow together, and the idea is that it's going to weld those two low motion joint, the two bone surfaces of the low motion joint together, so there's no more movement. Does that make sense?
So we have to do this in extreme cases of arthritis?
Yeah. If nothing else is working anymore, yeah, you'd be doing this. So that's the transarticular drilling. Laser ablation they've tried is not as effective as actually going in there and drilling it, but so that's what Dr. Eagle there is telling you. And then chemical, which is probably the most common one to do nowadays. It used to be done with this MIA, this monoiodide acetate. It's quite painful when you do it that way, so people have actually started using ethyl alcohol, which literally is just Everclear from the store. And so what you do, let's pretend I have a pastern joint with rig bone. Remember those? Remember the high rig bone and the pastern joint? What I would do is I'd go in there and put a needle into that joint, take a radiograph, and make sure I'm actually there, make sure that's not communicating with anything else, and then I just put alcohol into it. And then we send the horse home. A couple months later, he probably comes back for another injection. But over an average, I think, of 6 to 8 months, that joint just goes away. The alcohol just kills the cartilage in there, and you end up with a fused joint. Now, some joints, like that pastern joint, and to a slightly lesser degree, I think the distal hock joints do really well with that. And it's dirt cheap. All you're doing is putting Everclear in there with a needle and a radiograph. So that can be a really nice option if people don't have the budget to do a several $1,000 arthrodesis. Right? So pastern joint is great with arthrodesis. I'm putting plates and screws, but it's a surgery. It's expensive. It's aftercare. The other option is just stick a needle in it, put Everclear in it, which works reasonably well. Okay. Question 3. Test prep. No,
Tarsometatarsal,
Tarsometatarsal.
distal, intertarsal.
Which correspond to what letters?
D and E.
Okay. So remember your typical wear and tear, competing horse, usual type of arthritis that you'd be injecting steroids into down here, these two low motion joints. This one up here, the tibiatarsal, is where you have an OCD, and I know we haven't talked about that yet, we'll get to that. So that's where you'll have your bog spavin, right? Where's your bone spavin? It's just another word for that regular old degenerative joint disease, tarsal arthritis. So bone spavin, D&E, osteoarthritis, degenerative joint disease, D&E, bog spavin, OCD, we'll talk about it in a couple lectures. A. Well, A and B. This is all big. Okay. So what we're gonna do, questions on that before I make you go away? This one? Yeah, well, box spavin, A and B really, I think I just put those in there to confuse you. So A and B is all referring to just one joint, the tibiatarsal. So bog spavin is this whole big one up here. Remember, that's the big water balloon. And I'll come back, don't stress too much about bog spavin because I haven't even shown you the thing that causes bog spavin yet. But so that's where you'll get your OCD fragment, really fills up with fluid, you can feel it, it's like a big old water balloon. I'll show you pictures in a couple of lectures. D and E are the bone spavin, low motion joint, osteoarthritis. Half the horses going around at the horse show are getting steroids, put into their hocks, that sort of thing. So D and E are your typical wear and tear osteoarthritis. C is really
So the stifle, you mentioned a different term instead of osteophyte.
Enthesiophyte is what I use, just because that technically is in the collateral ligament of the stifle. What the difference between an osteophyte and enthesiophyte? Enthesiophyte means it's a bone spur occurring in a tendon ligament structure. So, all right, don't go anywhere. I'll get itchy. All right, buckle up, buttercup. So, I'm a little worried about getting through this stuff in time. What I'd like to do, if you guys don't object, is keep you about half an hour for lecture this afternoon at 1. I know that's a pain, you want to all get out of here after lunch. But I'd like to do a little bit of lecture this afternoon, and then we'll break off and do the language class. Language I didn't take terribly long. What time did we get out last